Welcome to this explainer for all the obstetricians, family physicians, midwives, nurses, and medical students joining us today. We are tackling a high-stakes, everyday challenge, urinary tract infections in pregnancy. Now, you know as well as I do, this isn't just about hastily prescribing a round of antibiotics. It's really about safeguarding both maternal and fetal health through evidence-based precision medicine. So, the crucial point is this: 20 to 35%. That is a massive chunk of pregnant patients with untreated asymptomatic bacteriuria who are going to progress to a symptomatic UTI, or worse, acute pyelonephritis. The stakes here are incredibly high, and catching these infections early literally alters the entire trajectory of a patient's pregnancy. Here is our roadmap for the journey today. We'll start with the pregnant urinary tract, look at asymptomatic bacteriuria, move on to acute cystitis, tackle acute pyelonephritis, and wrap up with stewardship and prevention. All right, Section 1, the pregnant urinary tract, physiology and pathophysiology. Okay, let's dive into this. Pregnancy creates what we can really only call a perfect storm in the urinary tract. You've got these high levels of progesterone causing smooth muscle relaxation, which leads to ureteric dilatation and reduced peristalsis. Add to that the mechanical compression from an ever-enlarging uterus, and, well, you get significant urinary stasis. This stasis, combined with vesicuratorial reflux, a relative state of immunosuppression, and an altered environment that's rich with glycosuria, it makes it incredibly easy for bacteria from the lower tract to ascend straight up to the kidneys. It's basically an open highway for pathogens. Moving to Section 2, asymptomatic bacteriuria, the routine screening case. Picture this. You'll see this case all the time. A 16-week pregnant patient comes in for a routine check. Her urine culture comes back showing at least 10 to the 5th colony-forming units per milliliter of E. coli. But she feels completely fine, literally zero symptoms. What's your immediate reflex here? Do you treat this, or do you just ignore it? You treat it, absolutely. By definition, asymptomatic bacteriuria, or ASB, is the presence of 10 to the 5th CFU per milliliter of a uropathogen on culture without a single clinical symptom. Because of those physiological changes we just talked about, major organizations like the IDSA and ACOG mandate screening all pregnant women at least once in early pregnancy. They do this specifically to catch this exact scenario before it evolves into something much worse. And the sheer impact of stepping in here, it's massive. Left untreated, the risks of preterm birth, premature rupture of membranes, low birth weight, and perinatal mortality shoot way up. But by stepping in with targeted antimicrobial treatment, we reduce the risk of that infection progressing to pyelonephritis by staggering 70 to 80%. That is a real game changer for the patient. Let's look at Section 3, acute cystitis and managing lower tract infections. And this brilliantly illustrates a really strict clinical divide we have to maintain. We just talked about ASB. Positive culture, no symptoms. Acute cystitis, on the flip side, presents with a sudden onset of very real symptoms like dysuria, urinary urgency, and frequency. But notice the key differentiator here: no fever. The absence of systemic signs like fever or chills is exactly what tells us the infection hasn't breached the upper tract yet. So, when you suspect acute cystitis, your diagnostic approach needs to be highly structured. After the clinical history, check the urinalysis for pyuria. Honestly, if it's absent, you should probably rethink the diagnosis. Then, send a culture. Here is a vital clinical pearl for us. In a symptomatic pregnant patient, a much lower colony count of just 10 to the 3rd CFU per milliliter can be entirely enough to confirm the diagnosis. Once that culture is sent, get empiric antibiotics started immediately. Oh, and another quick pearl: always remember to schedule a follow-up test of cure culture after the treatment is completed. Section 4, acute pyelonephritis. This is the escalation case. Let's raise the stakes for a second. Consider this escalation case. A 28-week pregnant patient presents to your clinic, or maybe she's in the ER. She has a fever of 38.5 degrees Celsius, severe flank pain, nausea, and her urinalysis shows significant pyuria. Ask yourself regarding her immediate disposition: does this require hospital admission? The answer is an absolute, resounding yes. Pyelonephritis in pregnancy is dangerous. Full stop. Up to 20% of women with severe pyelonephritis are going to develop major complications. We are talking about sepsis, bacteremia, acute kidney injury, and even acute respiratory distress syndrome, or ARDS. Plus, it can trigger hemolysis leading to anemia, and, critically, it's a huge catalyst for preterm labor. This requires rapid, aggressive intervention. There's no playing around here. For empiric IV management, you're looking for parenteral beta-lactams with excellent gram-negative activity. Ceftriaxone is definitely your preferred initial therapy here, largely due to its reliable safety profile in pregnancy, the convenience of once-daily dosing, and a relatively narrow spectrum compared to the big gun alternatives. Now, if you suspect resistance or the patient has recent hospitalizations, bumping up to cefepime or piperacillin-tazobactam is warranted. You'll notice fluoroquinolones are entirely absent from this list. Yeah, we generally want to avoid those completely in pregnancy. To be crystal clear on this, hospital admission for IV antibiotics is the standard of care. Outpatient initiation, strongly discouraged. The risks of rapid maternal deterioration and preterm labor are just too high. You need to keep the patient inpatient on IV therapy until she's been afebrile for 24 to 48 hours and her symptoms have clearly improved. Only then can you safely step her down to targeted oral therapy. All right, our final section, Section 5, Stewardship and Prevention, Choosing Wisely by Trimester. Let's move to and see how this builds. You see, antibiotic safety is literally a moving target across the gestational timeline. In the first trimester, we try to avoid TMP-SMX due to theoretical teratogenic concerns. In the second trimester, our toolbox opens up a bit, and agents like nitrofurantone and TMP-SMX are generally considered safe. But watch out as you hit the third trimester and approach term. You must avoid nitrofurantone if labor is imminent, say between 38 and 42 weeks. Why? Because of the very real risk of fetal hemolytic anemia. For routine ASB and acute cystitis, here are your standard oral regimens. We're typically running these for 5 to 7 days. Nitrofurantoin, amoxicillin clavulanate, and cephalexin are going to be your everyday workhorses. Fosfomycin is a fantastic single-dose option, but, and this is a huge but, remember this critical caveat. Fosfomycin and nitrofurantoin do not achieve therapeutic levels in the kidneys, which means they can never be used if you even slightly suspect pyelonephritis or if you need to step down a patient who is recovering from upper tract disease. Now, to prescribe effectively, you really got to know your enemy. Escherichia coli is the absolute dominant pathogen here. It causes roughly 70% of these infections. Klebsiella, Proteus, Enterococcus, and Group B strep make up the rest. And keep in mind, GBS carries its own complex intrapartum implications. But the real modern threat we're facing globally right now is the rising incidence of ESBL-producing strains. That resistance profile absolutely must dictate your empiric choices, especially if your patient has a history of resistant isolates. What about the patient who just keeps coming back? Particularly those with underlying maternal risk factors. Think diabetes, sickle cell disease, urinary calculi, or structural urinary abnormalities. Well, for these recurrent cases, we move to suppressive antibiotic therapy. Step 1, treat the active infection fully. Step 2, initiate low-dose prophylaxis. That's usually nitrofurantoin or cephalexin taken right at bedtime. And step 3, maintain this protective shield for the entire remainder of the pregnancy. If there's one single core philosophy I want you to take away today regarding antimicrobial stewardship, it's this. Empiric therapy gets the fire under control, sure, but you must always step down and tailor your therapy directly to the culture's susceptibility pattern. Your ultimate goal is to utilize the narrowest spectrum agent possible that is proven safe for that specific trimester. We've covered a ton of ground today. The physiology, the structured diagnostics, the critical escalation to pyelonephritis, and the tricky nuances of trimester-specific stewardship. So I'll leave you with this provocative thought. Knowing there is up to a 35% risk of progression to pyelonephritis for untreated asymptomatic bacteriuria, are we actually screening our high-risk obstetric populations early enough in our daily practices, and are we following up effectively? I encourage you to evaluate your own protocols today and keep advocating for rigorous, evidence-based prenatal care. Thanks so much for joining me on this explainer, and keep up the fantastic work out there in the clinic.